shoulder on 18 years ago, and the glenoid failed after 18 years. And I realized I've been in practice here long enough that now I'm seeing my own failures coming back to me. But this is a short-term problem, right? Subscap failure is what we worry about when the shoulder goes bad in the first year. And how do we avoid that? And it's still a problem. If you look at the literature, there's still a high number of patients who have early subscap failure. And then it turns into a long debate every time we have a meeting. Do you peel? Do you do an osteotomy? Do you do a tenotomy? Or what if you just don't cut it at all? And the idea here is that by preserving the muscle, you can expedite rehab. As a case example, and I'm violating HIPAA, Mark Frankel, I did his shoulder replacement, and non-compliance comes to mind. Wearing his immobilizer was suspect at best. Thank God his shoulder's still working. But, so do we really expect our patients to wear an immobilizer for 6 weeks? Or, you're showing some examples of muscle transfers. At least in Tampa, if I had someone wearing a pillow for 8 weeks, I don't think it would happen unless you could put a koozie and a Bucks TV on their stand so they could watch it. So there's a lot of downsides to fixing it. And maybe we can avoid those things by doing a subscap sparing approach. And so I kind of looked at the different approaches, and I kind of looked at what Buddy did, but I couldn't do this without some of the advances in technology. I mean, it's going to be a little harder to trial, but now you have Blueprint or other different kind of 3D planning technologies. Therefore, you can determine sizes ahead of time, and the accuracy is better. You can kind of have an idea where the osteophytes are. We know that as a human, when we try to put a pin in, we're off by 10 degrees. For instance, if we get to robotics, now we can get down to 1 degree for putting our center pin in.